Hey, Pediatric team, let's break down blood, defense, and diagnoses. Welcome to the deep dive. This is where we take the source material you provide articles, research, your notes, and really break it down into usable knowledge. And today, wow, you've given us a very comprehensive set of sources on pediatric hematological, immunological, and oncological disorders. It's dense stuff, definitely complex, but our goal here is to navigate it together and pull out those key insights just for you.
Absolutely. And it's so important to remember, these aren't just conditions, they deeply affect children and their families. We're diving into how these crucial systems work, or sometimes, sadly, how they don't. The blood carrying oxygen, the immune system fighting off threats, and, well, the very basics of cell growth that can go wrong in cancer. Understanding the science is critical, yes, but approaching it with real compassion is just as vital.
Couldn't agree more. So the source material itself is pretty extensive. It covers a wide spectrum of these conditions, specifically how they show up in kids.
Right. And our mission, if you will, is to distill the core information. We're talking pathophysiology, what's actually happening inside the cells, key assessment points, the diagnostic tools that give us answers, and importantly, the interventions and care strategies. Not just the medical side, but for the whole family unit. We really want this to be clear, actionable, and, sensitive.
Okay, let's get into it. We'll start with the blood system hematological disorders. The sources wisely begin with the basics. Hematopoiesis, that amazing process in the bone marrow where all blood cells get made. And specifically, erythropoiesis, the making of red blood cells. Those little oxygen taxis, they live about 120 days, then they're sort of retired.
Exactly. And the key insight there is when any part of that production line gets disrupted, or maybe the cells themselves are faulty, well, that's where these hematological disorders start popping up.
A classic example, and the source details as well, is iron deficiency anemia. It's highlighted as the most common kind, especially in infants. And there's a really specific link made, dietary deficiency, often tied to too much cow's milk before, say, 12 months. The defining feature, small, pale red blood cells.
So what are you looking for in assessment? The source mentions irritability, poor muscle tone, maybe getting sick more often. That distinctive pale, almost porcelain-like skin, even delays in learning. It's actually why the AAP recommends that hemoglobin screening right at 12 months.
And confirming it. The material walks us through the tests. A CBC, looking closely at those red blood cell indices, you'll find low serum iron, low ferritin levels, but high TIBC, total iron binding capacity. Basically more empty seats on the bus because there's less iron. And checking erythropoietin levels too.
Interventions can start simply, dietary changes. Then oral iron preps are common, like ferrous fumarate. Oh, and a practical tip from the source. For liquid iron, use a straw. Helps avoid staining teeth. For certain injections like iron dextrin, that Z-Trek method is crucial. Prevents staining, prevents irritation.
Caregiver education is huge here. We need to really emphasize iron-fortified formula, why holding off on cow's milk until after one is important. Possibly needing iron supplements for breastfed babies, not getting enough iron solids yet, and pointing them towards iron-rich foods, organ meats, legumes, fortified cereals. It's all about prevention and sticking with the treatment.
Okay, staying with the blood system, let's look at platelets. Acquired thrombocytopenia, this means a decrease in platelets, which, are essential for clotting. The source connects this drop to things like infections. It gives specific examples like Rocky Mountain spotted fever or malaria or even exposure to certain chemicals. The good news, the insight here, is that the platelet count often bounces back once you remove whatever caused it.
So what are the red flags during assessment? Spontaneous bleeding is key nosebleeds, bleeding gums, blood in stool or vomit. Petechiae, those tiny purple spots, especially over bony areas, are classic. And you definitely ask about recent infections or any chemical exposures.
Diagnostics are pretty straightforward. A decreased platelet count. The source gives the normal range, roughly 140 to 400,000. A dip below that is the main finding.
Interventions, mostly focused on preventing injury that could cause bleeding. Think soft toothbrushes, carefully watching for any bleeding signs, and specifically avoiding things like IM injections, unnecessary suctioning, and definitely no aspirin because that interferes with platelet function. Steroids might be used sometimes. Modifying activities is key.
And what do we tell caregivers? Explaining potential steroid side effects like fluid retention, making sure they take steroids with food, helping them understand which activities are safe based on the current platelet count, stressing avoiding the cause if known, and really importantly, supporting the child's self-image through all this.
Okay, now we get into genetics, sickle cell disease. The source calls this the most common genetic hemoglobinopathy. The core problem, it's an abnormal hemoglobin S, that makes red blood cells literally sickle up. They go from that nice round shape to a crescent moon.
Right. And the crucial insight into why SCD is so damaging is because these sickled cells are stiff. They die early, sure, but they also block blood flow. Imagine tiny traffic jams in blood vessels all over. This causes tissue damage, leading to things like delayed growth, serious lung issues like acute chest syndrome, stroke risk, and those incredibly severe pain episodes. Inheritance is autosomal recessive if both parents carry the trait. It's a 1 in 4 chance for each child. The source notes the prevalence, especially that about 1 in 13 black babies in the U.S. are born with the trait, and kids often don't show symptoms until maybe 4, 6 months old because they still have that protective fetal hemoglobin.
So key assessment points really revolve around those blockages. The vaso-occlusive crisis, that's the hallmark pain episode, often starting as hand-foot syndrome in infants. Acute chest syndrome, that's a life-threatening lung problem, need to watch for that. Sequestration crisis, where blood gets trapped in the spleen, making it swell up fast. And CVA, or stroke, watch for neurological signs. Beyond the physical, the source notes the huge psychosocial toll of repeated hospital stays and chronic pain.
Diagnostics involve first screening with something like a sickle turbidity test, sickle dex, just to see if hemoglobin S is there. But the definitive test is hemoglobin electrophoresis. That actually measures the amounts of different hemoglobin types, giving a clear diagnosis.
Interventions focus on managing symptoms and preventing complications. Pain management is absolutely number one. Analgesics, yes, but also distraction, complementary therapies. Hydration is critical, especially during a crisis. Antibiotics for infection prevention. Penicillin prophylaxis starting early is a big one mentioned. Hydroxyurea is a medication that can help reduce crisis frequency. Treating metabolic acidosis, PT for joints, sometimes splenectomy, and even HSCT in severe cases are all mentioned.
Caregiver education for SCD is extensive. Things like genetic counseling resources are vital. Teaching them to recognize infection signs, especially if fever over 38.0 Celsius or 100.4 Fahrenheit that's critical, it can escalate fast. Prophylactic penicillin before dental work, making sure immunizations like HIB, pneumococcal, meningococcal are up to date. And beyond the medical, talking about how chronic pain affects self-concept, maybe leads to depression or anxiety. Building that strong relationship, answering questions. Oh, and the source included a really important point on cultural competence, specifically mentioning discussing blood transfusions sensitively with families of the Jehovah's Witness faith. Really highlights the need for informed, respectful conversations.
Yeah, that's crucial. Okay, another serious bone marrow issue,
Uh-huh.
aplastic anemia. The
Mhm.
source defines this as a deficiency in everything red cells, white cells, and platelets, pancytopenia, caused by damage to the bone marrow itself.
Assessment might uncover just profound fatigue, maybe a history of an illness or injury that just took way too long to heal.
Diagnosis is confirmed with the CBC, showing that pancytopenia, a low reticulocyte count, meaning the marrow isn't making new red cells, and the key test, bone marrow aspiration. It shows yellow, fatty marrow instead of healthy red marrow.
Interventions often involve immunosuppressive therapy, trying to stop whatever's damaging the marrow. Carefully monitoring blood transfusions, which are often necessary, and strict infection prevention hand hygiene is just fundamental. The source actually details steps for preparing and monitoring transfusions, stressing vital signs, and watching for reactions.
A key educational point here. Bone marrow transplant might be a better option before too many transfusions. Why? Because transfusions can make the body sensitive to HLA markers, making it harder to find a transplant match later. Empowering caregivers, involving them, supporting a balanced diet, meat, greens, legumes, also important.
Okay, back to clotting disorders hemophilia. This is a lack of specific clotting factors. Factor 8 for hemophilia A, factor IX for hemophilia B. The insight is simple. Without enough factor, you can't form a stable clot. Leads to prolonged bleeding. It's X-linked recessive, so mostly affects males. Females are typically carriers.
Assessment often uncovers an unusual bleeding history. Nosebleeds that just won't stop, lots of bruising. Hematologic bleeding into joints is classic, very painful, can cause long-term damage. Hematomas, blood in urine. It often shows up when toddlers start moving more, falling. Oral bleeding after minor mouth injuries is a common early sign.
Diagnostics will show a prolonged PTT, that's a specific clotting test pathway, and then confirming low levels of the specific factor, 8 or an ICE.
Interventions center on replacing that missing factor, usually with infusions of factor VIII concentrate. DDAVP might be used for mild hemophilia A, corticosteroids for joint bleeds sometimes. NSAIDs for pain, but cautiously they affect platelets. Aspirin is a definite no-no. Chronic codeine use also discouraged. Supportive care like exercise and PT is essential for joint health.
Caregiver education is heavily focused on injury prevention. Close supervision, helmets, avoiding contact sports, soft toothbrushes, using venipuncture instead of finger sticks for blood draws. A medical alert tag is a must. Prophylaxis regular factor infusions to prevent bleeds is key. The source mentions kids learning self-administration, which is huge for independence. Resources like the National Hemophilia Foundation are great. And yes, considering family dynamics, finances, that's part of the whole picture.
Yeah, and the source made a really good point about promoting independence in older kids and teens with hemophilia, balancing safety with letting them socialize, build self-esteem, manage their own care,
Yeah.
navigating that adolescent invincibility complex carefully.
Absolutely. Okay, last one in this section. Lead poisoning, caused by ingesting or inhaling lead, leads to significant physical and mental issues. A specific insight from the source. Kids with iron deficiency actually absorb lead more easily.
So prevention and proactive assessment are everything here. Risk assessments are recommended in multiple ages, from 6 months up to 6 years. Assessment means asking about sources, old paint, soil, water pipes, even cigarette smoke exposure. Signs can range from anemia-like symptoms, abdominal pain, vomiting, lethargy, to CNS signs like hyperactivity, learning problems, hearing issues.
Diagnosis is based on blood lead levels. The source gives clear thresholds. Over 5 millicgdl means exposure, needs action. Over 45 needs chelation therapy to remove lead. And levels over 70 millicgdl carry a significant risk of permanent brain damage. Scary stuff.
Interventions are twofold. First, stop any further exposure. That's priority number one. Then, for those higher levels, chelation therapy, often injections, helps the body get rid of the lead.
Caregiver education focuses on making the environment safe, teaching proper cleaning for lead dust wet cleaning, not dry sweeping, maybe even relocation if the home is too contaminated, and ensuring follow-up with a developmental specialist to address any potential long-term effects.
Okay, let's shift gears now. Let's look at immunological disorders, the body's defense system.
The source primarily focuses on aphids in children here. AIDS develops from HIV infection. In kids, the most common transmission route discussed is mother to child in utero, during birth, or breastfeeding. Prevention strategies are key. For older kids and teens, transmission via blood and sexual contact becomes relevant.
And the key insight into how HIV works is that it targets T lymphocytes, those crucial immune cells. This suppresses the immune system, the viral load goes up, and it can also cause other blood deficiencies like neutropenia and anemia, making kids vulnerable to serious infections. The source really stresses that starting treatment early dramatically improves their prognosis.
Assessment findings might include persistent swollen lymph nodes, skin rashes, failure to thrive, enlarged liver and spleen, persistent oral thrush, swollen salivary glands, chronic diarrhea, a lot of potential signs.
Diagnostics in infants born to HIV-positive moms are tricky. Maternal antibodies can cause false positives on standard antibody tests like ELISA for months. So the preferred test in infants is the HIV PCR test, looking directly for the virus's genetic material. Antibody tests, ELISA plus Western blot, are reliable after about 18 months.
Interventions rely on heart highly active antiretroviral therapy. That's a combination of meds. The source mentions zidovudine, AZT, as safe even in pregnancy for prevention. Recommended immunizations are given, but sometimes adjusted based on immune status. Nutritional support, high-calorie diets are important. Maintaining confidentiality, using standard precautions always, and aggressively preventing and managing opportunistic infections. Pneumocystis pneumonia, TB, are critical.
Caregiver education involves teaching non-drug pain relief methods, stressing the absolute need for strict adherence to ART timing. It's crucial for effectiveness. Providing support for the huge social and family challenges, educating schools or daycares carefully, fostering positive self-concept, fighting stigma, and supporting the child living with a serious illness.
All right, now let's move into the complex area of oncological disorders, cancer in children. When cells basically grow out of control, the source defines cancer as that unregulated cell growth, forming tumors benign or malignant. Malignant ones can metastasize, spread.
The cause is often unknown, but the source mentions possible links. Chemical carcinogens, radiation, viruses, genetics, a key insight highlighted. Childhood cancers often have specific patterns. Peace in infancy early childhood, then again in adolescence, different from many adult cancers. And importantly, the source emphasizes that childhood cancer is often treatable. Cure is a realistic goal today.
General assessment points can include pain from the tumor, cachexia, that wasting with anorexia and weight loss anemia causing fatigue, increased infection risk from the disease or treatment, bruising from low platelets, sometimes blood in the urine.
A critical nursing priority, the source details, is calculating the absolute neutrophil count, the ANC, for infection risk. The formula is there, Add the percentages of bands and segs from the diff, convert to a decimal, multiply by the total WBC, the crucial number. An ANC less than 500 means high risk for infection.
Diagnostic testing is comprehensive. CBC, of course, checking that ANC. Lumbar puncture to check the CNS. Imaging CT, MRI, ultrasound. Biopsy for definitive diagnosis. Bone marrow aspiration. And increasingly, advanced genomics, precision medicine, looking at the cancer's specific genes.
Treatments often combine approaches: surgery, chemotherapy based on protocols, radiation, bone marrow transplant for some types, and biological response modifiers. These are really interesting. They work with the immune system or target cancer cells specifically. The source mentions types like monoclonal antibodies, interleukins, CRRT cells, and meds that boost blood counts, like filgrastim for white cells, or erythropoietin for red cells.
Nursing care for these kids is incredibly complex. Quick triage is essential. Implementing neutropenic precautions, strict isolation, hand hygiene, dedicated equipment is vital for infection control. Cardiopulmonary monitoring, watching for hypotension suggesting sepsis, avoiding invasive procedures if possible, accessing central lines carefully, aseptic technique using 10 millilode or larger syringes.
Getting labs done fast is key. Blood cultures, if infection suspected, BMP, CBC with that ANC, type and screen, PT-PTT. If a neutropenic child has a fever, getting antibiotics started within 60 minutes is a critical goal mentioned. Acetaminophen for fever. And the source strongly emphasizes a broad, multimodal approach to chronic pain, considering everything cognitive, emotional, physical, cultural, social needs.
Right, and complementary therapies like aromatherapy get a mention for general well-being. Other nursing interventions, managing nausea with antiemetics, hydration, nutritional support, which is often a huge challenge, preventing central line infections, age-appropriate care, and just listening, offering support. Non-pharmacological pain management, too, medical play, visual aids, distraction, these are really effective.
The source also flags specific life-threatening oncology emergencies: tumor lysis syndrome, septic shock, hyperleukocytosis, extremely high white counts, and increased intracranial pressure, ICP. Knowing the signs is critical.
General caregiver education points include helping the child maintain some sense of control, building strong support systems, coping with uncertainty and potential loss, fostering hope, and connecting families with financial support resources, often badly needed.
Let's dig into treatment side effects, specifically radiation therapy. The source explains the basic principle. Radiation damages rapidly dividing cells, kills cancer, yes, but also hits healthy dividing cells.
And the potential side effects listed really show how widespread that impact can be. Skin reactions, redness, hair loss, nervous system long-term learning issues, headaches, eyes, heart, lungs can be affected. GI side effects are common mucositis, those painful mouth sores, nausea, diarrhea. GU issues like cystitis, potential sterility. Hematological effects, myelosuppression, low counts, skeletal issues, slow growth, and just general fatigue. It's a lot.
The source also mentions different radiation techniques in the safety principles: time, distance, shielding.
Okay, specific cancers. Leukemia. Most common pediatric cancer, about 28% of cases. The key insight, it's a cancer of the bone marrow and lymphatic system. You get overproduction of immature white blood cells even if the functional count is low. They crowd out healthy cells. But the source stresses survival rates are much better now thanks to targeted therapies. Potential causes mentioned: chromosomes, radiation, chemicals.
The source outlines the main types. All acute lymphocytic leukemia is most common in kids. Then AML, acute myeloblastic leukemia. Chronic forms, CML and CLL, are much rarer. Symptoms can overlap, but might differ slightly. All often presents with bone pain, fatigue. AML might show more bleeding, fever.
General assessment for leukemia covers symptoms from anemia, weakness, fatigue. Respiratory symptoms may be from a chest mass. Neutropenia, meaning infection risk. Thrombocytopenia, causing bleeding, bruising, sometimes blood in stool or urine, bone pain, enlarged liver spleen nodes, and potential CNS signs if it's spread headache, vomiting, vision changes.
Diagnosis hinges on a bone marrow test that's definitive. A CBC shows abnormal counts, low red cells, platelets, abnormal white cells, though the total WBC can be high, low, or normal. Lumbar puncture checks the CNS.
Interventions include transfusions, chemotherapy is the main treatment, and rigorous infection prevention. Caregiver education emphasizes hand hygiene, avoiding things like plants due to fungus risk. Basic nursing care focuses on preventing infection bleeding, promoting nutrition.
Lymphomas are another type, affecting the immune system. uncontrolled growth of lymphoid tissue.
And the source clearly differentiates the two main types. Hodgkin's lymphoma often starts in one node area, has specific Reed-Sternberg cells, and is generally more curable in kids. Non-Hodgkin's lymphoma, or NHL, is often more aggressive, involves peripheral nodes, spreads more widely, and includes subtypes like Burkitt's. Staging is crucial for both.
Assessment often starts with enlarged lymph nodes, maybe in the neck or above the collarbone. Symptoms can also come from those nodes pressing on things: airways, intestines, nerves. Systemic symptoms, sometimes called B symptoms, include unexplained fever, weight loss, night sweats, cough, generalized itching.
Diagnostic testing is comprehensive, detailed in a source table. Includes blood work, CBC, coags, ESR, uric acid, liver function, T-cell function. Imaging is key: CT, gallium scan, chest x-ray, bone scan, lumbar puncture, and bone marrow aspiration check for spread.
Interventions usually involve chemotherapy first, maybe radiation prep, helping manage fatigue. Sometimes immunotherapy. Medical play helps kids cope. Preventing infection is vital standard precautions, maybe isolation, ensuring necessary immunizations like pneumococcal, meningococcal.
Caregiver education covers monitoring activity, rest, discussing the high risk of sterility and options like sperm banking, thorough education on the disease, procedures, side effects, long-term issues, supporting families and discussing feelings. Oh, and the source detailed practical points for chemo administration. Checking understanding, antiemetics first, double-checking identifiers, dosages, aseptic technique, close monitoring, recognizing side effects, handling hazardous drugs safely.
Brain tumors, most common solid tumors in kids. Classified by location, supratentorial or infratentorial, potential genetic or environmental causes. Source lists common types: medulloblastoma, glioma, astrocytoma. Symptoms really depend on location, growth rate, and the child's age.
Assessment points often relate to increased intracranial pressure, or ICP, from the tumor taking up space. In babies, maybe an increased head size; older kids. Classic signs are morning headache, nausea, vomiting. You'd monitor pulse pressure, check for sluggish or unequal pupils, weak hand grasp.
Diagnostics rely heavily on imaging, especially MRI, to see the tumor's location and extent. CT, angiography, EEG might be used too. Lumbar puncture, only if there's no sign of increased ICP, risk of brain herniation otherwise, which is life-threatening. Biopsy during surgery gives the definitive diagnosis. Special scans like SPECT, PET add info, and the source has a great section on preparing kids for tests. Tailored to the development, be honest, allow crying, use play, distraction, caregiver presence, anesthesia, pain control, acknowledge feelings, use rewards. Really practical advice.
Interventions involve surgery to remove as much tumor as possible, radiotherapy but used very cautiously in young kids due to brain damage risk, chemotherapy, assessing response to targeted therapies, post-op, meticulous wound care, monitoring drainage. During chemo, watching the mouth for stomatitis, monitoring for seizures, changes in posturing, vitals, vision is critical. Specifically BP, pulse pressure, frequent pupil and LOC checks, motor and reflex checks. Positioning post-op is key for ICP. HOB up 30 degrees for supratentorial, no Trendelenburg. For infratentorial, wait for gag reflex before fluids. Preventing vomiting is vital. Careful 5V fluid management. Pain control, always.
Yes, and the source highlights promoting nutrition and hydration as a critical component, often really tough. Frequent small amounts involve the child, favorite foods, fortification, watch weights closely.
Caregiver education includes explaining the plan, survival rates, referencing data like in the source tables, encouraging emotional support, social connections, even virtually, discussing potential long-term challenges, memory, motor skills, learning, behavior, and the need for ongoing monitoring of growth, hormones, especially at puberty, preparing them for the long haul.
Okay, Wilms tumor, cancer of the kidney. The insight here is its origin develops in fetal life, often found as a belly lump by parents around age 3 or 4. Usually affects one kidney, sometimes both.
Assessment often starts with that abdominal lump. Maybe waistband area feels tight. Pain is possible. Increased BP can happen because the tumor affects kidney hormones. Unexplained fever, too.
Diagnostics include checking for associated congenital anomalies, abdominal CT or MRI, and labs CBC, liver function, urinalysis, renal function.
Now here is the absolute critical non-negotiable point. The source is emphatic. Do not palpate the tumor site. Don't push on that belly lump. Why? It's encapsulated. Palpating can rupture it, spill cancer cells, increase metastasis risk. Hugely important.
So interventions include giving clear info on treatment trials, careful manual BP monitoring, strict INO, likely chemo before surgery to shrink it, strict aseptic technique for central lines, monitoring nutrition, loose clothing around the waist.
And caregiver education must reinforce that. Do not palpate the tumor. Avoid pushing or lifting in that area. Emphasize getting care at a major center experienced in childhood cancers. Discuss long-term side effects, genetic counseling possibility, and supporting parents who might feel guilt. That's crucial compassionate care. Educating on chemo side effects, surgical risks too.
Finally, the source covers hematopoietic stem cell transplantation, HSCT, a powerful option for severe conditions, plastic anemia, some leukemias, lymphomas, immunodeficiencies.
The basic process, high-dose chemo, maybe radiation, to destroy the cancer and wipe out the bone marrow. Then, healthy stem cells are infused IV to replace the diseased marrow. Stem cells can be autologous from the child, allogeneic from a donor, or from umbilical cord blood. Peripheral stem cell transplant uses apheresis to collect cells from blood.
Assessment confirms the condition warrants this intense therapy, and preparing the child and family for that long isolation period while the immune system recovers.
Diagnostic testing here is absolutely critical, especially for allogeneic transplants. HLA matching, it's paramount, the insight. Poorly matched donor cells cause graft versus host disease, GVHD. The donor immune cells attack the recipient's body. Histocompatibility testing minimizes this risk. The source describes GVHD types. Acute, 7-30 days post-transplant, hits gut, liver, lungs, skin, and chronic. Around 100 days post affects similar organs plus oral mucosa, skin hardening. Treatment for GVHD involves high-dose steroids, other immunosuppressants.
Interventions include giving that intense chemoradiation, the actual stem cell infusion, strict asepsis for central line care infection is a huge risk, and meticulously monitoring fluid balance, INO, and nutrition, often IV initially.
Caregiver education is extensive, covering all the meds, non-drug symptom management techniques, detailed care for the venous access device, and crucially encouraging and supporting continued caregiver participation. It empowers them, gives some control, involving siblings if safe, normalizing the huge stress, proper technique for accessing lines, rigorous hand hygiene fundamental.
The source also briefly touches on palliative care. Using the WHO definition, improving quality of life for patients and families facing life-threatening illness. The key takeaway is considering patient and family preferences and goals throughout, not just at the end.
So, stepping back from all this detail, we've really covered a lot from these sources. A deep dive into the complexities of blood, immune, and cancer disorders in kids. It's challenging territory, absolutely, but also filled with resilience and remarkable progress in how we diagnose and care for these children.
Yeah, from those basic processes of blood production and disorders like anemia and hemophilia, to the immune system battling HIV, to the really intricate world of pediatric cancers, leukemia, lymphomas, brain tumors, Wilms tumor, the source material consistently highlighted the critical role of detailed assessment, precise diagnostics, tailored interventions, and that absolutely essential caregiver education.
And this knowledge isn't just theoretical, right? It directly empowers care teams and, most importantly, the families navigating these incredibly tough journeys. It allows for more informed, effective, and truly compassionate care.
Which brings us to a powerful thought drawn right from this material. We've seen how vital aggressive treatments chemo, radiation, transplant are for survival in childhood cancer. But the source also details significant side effects, both immediate and long-term, affecting physical growth, cognitive development, even fertility down the road. So the question is, how do we, as care teams, families, patients, how do we balance that intense fight for life right now with the ongoing lifelong need for quality of life and managing these long-term impacts?
It's a profound question. It really underscores the lifelong journey for these survivors and their families. Demands continued support, vigilance, advocacy, long after the initial treatment ends.
A really crucial challenge to keep in mind. That wraps up our deep dive into this comprehensive source material on pediatric hematological, immunological, and oncological disorders.
Stay strong, stay smart. See you in the next one.